Hi, everybody. So, welcome back to the new year, and apologies for the um, few weeks that we've had without any sort of uh, without any sort of presentations and things like that. And I'm hoping that that will change. And what I'm going to do now is I'm actually going to start with the topic that I did want to do towards the end of last year. And thank you to all of those who wish me well during my recovery. I'm slowly but surely getting back to normal, and hopefully we'll start getting back into the usual set of things, which is to do ECGs 1 week, radiology 1 week, and emergency department topics 1 week. And yeah, hopefully it should go well. So what we're going to do is we're going to talk about delirium, but we're actually going to talk about it in 2 stages because it's an extremely long presentation. I don't want it to bore people, and it is an extremely long, important topic. So what we will do in the first part is that we're just going to talk about the basics, the pathophys, what goes on, things like that. And I'm going to change this over to my what you call a presenter view, so that you guys will also see my notes and that you can also read through it while we're going through it as well. All right, so I'm just going to do that. Okay, so you're more than welcome to have a look at my notes as well, if that makes it a bit easier for you. So what happens is that why are we so worried about delirium in the elderly, and specifically in these acute settings? The problem is, especially in the elderly, and generally the patients who we get in the elderly patients who we get tend to come in very acutely. And the problem is that most of the time it's actually a symptom of severe underlying disease rather than primary psychosis. That's the problem, and unfortunately they may present exactly like an acute psychosis and are often misdiagnosed as having an acute psychosis, when in essence, they're really having an underlying organic problem. And by the time somebody picks it up, it can actually be too late. So that's the reason for us to go through this. So we'll go through a lot of the causes. And then, like I say, next week, we're going to do a second part where we'll go through a case study on this and cover some other aspects of it. Okay. So it's not to explore delirium as a disease, but rather how do we approach delirium in the acute setting in relation to the elderly patient. And then we'll talk about some pathophysiology and newer theories as well. Okay. So let's try and get the next slide. Okay. All right. So what are the considerations? So the thing is, in the elderly, primary psychiatric disease, in other words, Gogo comes at the age of 75. She is having hallucinations. She's having audiovisual hallucinations. She's throwing things at people. She's having aggressive attacks. It's the first time in her life that it's ever happened. It is very unlikely that psychiatric cause is the primary cause for this. It is a differential, but it's kind of like a differential of exclusion. You have to go through everything else and make sure nothing else is there before you get to this point to say, you know what, listen, this is a primary psychosis. And the problem is it's quite difficult, especially in most of our settings where you have a busy emergency department and you have somebody who's coming in and they're really not looking well. They really look like they are psychotic, but majority of the time it's not, especially in the elderly. Now you would say, what is the elderly? They say above 50, but it depends on the study. Some studies say above 60, some say above 50. I would generally say above 60. We've seen a lot of primary psychosis between 50 and 60, especially in long-term drug users and things like that, or new drug users who are starting at that age. So what are the causes for acute delirium? If we just look down here at the notes. So it can occur in any age group. It's 1 to 2% of the population can develop an acute delirium, and 12 to 14% of elderly hospitalized patients. Right? Rates as high as 60% in post-operative and ICU patients. So delirium and psychosis are not the same thing. Remember, delirium and inability to have a proper cognitive response, confusion, disorientation. That's basically what we're talking about. Okay. So it's a difficult thing to deal with in the elderly because most of the complaints are non-specific, and clinical examination can be inconclusive because there are multiple comorbidities that go along with the elderly. How do you know whether this whether this diabetic patient is having symptoms secondary to diabetic vasculopathy, or is it now a psychosis? There's so much to say. Is this patient had a CVA? What's going on? It's very difficult. So at least you need to have an approach to how to do it. The thing is, if you show that you've looked for things and you haven't found them, and then you give a diagnosis of psychosis, when the patient is in that area that needs to look after those patients who have psychiatric disorders, they are never meant to just be dumped there. And if you are somebody who's working in the psychiatric ward, remember, the primary diagnosis may be wrong. You still need to look into it and see, did they miss something, especially in the elderly? All right. Okay. So you need to have an approach that rules out the benign, the acute from the chronic, and the easily treatable from the complex. Okay. So let's go to the next one. Sorry, let me get that up. So what is delirium? So it's a transient reversible syndrome that is acute and fluctuating and which occurs in the setting of medical illness. All right. So these are the different causes: hypoxemia, metabolic derangements, global impairment of cerebral metabolism, decreased synthesis and release of neurotransmitters, certain drugs, especially neurotransmitter, that cause a neurotransmitter imbalance, disruption of synaptic communication, systemic inflammation, activation of prime microglia, increased cytokine levels in the brain. What are we talking about here? We're talking about anything from pneumonia to trauma to polypharmacy. There's so much that can cause it, So it is regarded as acute and fluctuating, right? A chronic disease in function cannot be classified as a delirium, but an acute change in a chronic state can be called a delirium. Right? So it is fluctuating. I'll cover the different states just now. So there's 3 pathways. So pathway number 1 will cover infections, metabolic diseases such as renal and diabetic cause, and changes to cerebral function. It is important to know that any hypoxemia may cause such a state. Sorry, I'm looking at the wrong one. So these are the disease states that we're looking for. Okay, then drugs we'll talk about as well. And systemic inflammation has so many causes in the elderly. Again, we'll talk about it in a little while. But note that the common end path is neurotransmitter disruption and synaptic communication. So those get disrupted. The type of neurotransmitter then determines the clinical manifestations. So it's especially important when noting the drugs that are being taken. And synaptic communication is more of an issue with the other causes stated. So there's a lot of things that go into delirium. It's an extremely interesting topic, I must be honest. Trying to distill it a little bit. All right. So what are the types? So there's a few main types. The first type is the hypoactive type. So it's self-explanatory. But generally, you get this patient who's lethargic, poorly responsive, almost seems depressed, may even mimic somebody with hypothyroidism. All right. So there's decreased global function, but especially cognitive impairment, more commonly seen due to direct neuronal injury, and the inflammatory response, sometimes seen, may mimic depression completely. Patients are slow to respond, lethargic, and sometimes even catatonic. So if you were to see an elderly person like this, especially if it's the first episode, remember that not somebody who's got a chronic history of depression, catatonia, that's different. I'm talking about somebody in an acute stage. Don't rush to a psychiatric diagnosis, all right? So depression should only be suspected after exclusion of other causes and in conjunction, with the spelling, with the history suggestive of such as recent traumatic events, or the two grandkids died this morning in a fire. I mean, that you would expect anybody to become depressed, right? So that's different, But if there's no history suggestive of that, it's very, very difficult to have a look, right? And then hypothyroidism has been linked to seasonal affective disorder in the elderly. It's not as common in our climate, but especially those who are in cold countries. And they talk about seasonal depression there, and it affects the elderly there to quite a great extent, right? So these are our hyperactive patients. Now, these are the ones that normally cause the most confusion, because it mimics acute psychosis, all right? And most often seen when there is a neurotransmitter disruption. Now, in this patient, she looks hypothyroid, like she's got hypothyroidism, a bit of exophthalmos, but that's besides the point. I just picked the picture just so that you guys get the idea, all right? So they tend to have disorganized behavior and speech, the restlessness, they're agitated, they have hallucination, hypervigilant, paranoid, things like that. And especially after certain drugs are being used. Now, these are not illicit drugs. These may just be polypharmacy from the normal medications, acute infections, and certain CVAs may also lead to this, right? Now, it's difficult to get the CVAs diagnosed, but acute infections can be easily diagnosed clinically, right? So if there's no history of primary psychiatric disease in these patients, look for an underlying cause, right? Now, this is when we start to talk about an approach, and we'll move into the sequence of what you need to do based on the case study, which we'll do next week, all right? But you'll need to keep this in mind, right? So remember, there's two types, hypoactive and hyperactive. Hypoactive, a bit easier to understand. Hyperactive, you yourself become stressed out for the simple reason that you have this patient who is now behaving abnormally. That's it, okay, I see the case came up already. I just want to make sure we're going to go. We're probably going to go up to just about there. So just a few more slides, and then we'll do a full discussion of the case. Let me just change this around. Because I don't want to touch the case this time. Sorry about that. I just wanted to get you guys ready. So my apologies for that. Okay, so when we talk about drugs, what are we talking about? So when we think drugs and psychosis, we often think of illicit drugs. Now, in the elderly, you think more of your prescribed medications. A lot of them are on polypharmacy. So they're receiving stuff for high blood pressure, for their diabetes, for their arthritis, for their heart condition, for whatever, they're receiving what you call it, statins, plus blood thinners, plus everything that you can name of. And now they've developed a small bleed, and now they present as psychotic. These are the things that happen, patient's BP is in the ground. These are things that you have to look at. And the sad part is, as people get older, they tend to take unnecessary doses, extra doses. They forget their doses and incorrect timings, especially in those who are hypoglycemic. We notice it quite often. So a drug history is the first and easiest piece of information to obtain. Patient on analgesia buys extra analgesics as the first are not working. As an example, now he's taking tramadol 4 times a day. Plus to that has added 2 NSAIDs. Plus Disprin, not knowing Disprin is also an NSAID, and having 10 Panados because one goes by the name of Proleaf, the other one is called Sanpudin, and the other one is called Panado. So they're taking large amounts of paracetamol and causing liver damage. So these are the things that patients do, unfortunately, So what happens is you often get this the situation where patients will come to us in the hospital, then go to their GPs because that doctor gives them good medication. So now they're on 2 types of antihypertensives instead of 1. And the GP is there to sell his products. Even those of you who are GPs who are listening to him, there's nothing wrong with that. You're running a business, So if the BPs are slightly up, patient is already, for example, on Redact, we don't take a proper history, and now the patient comes and you add more Redact, or you add a bit of a Tenolol, or you add something because the patient says they're feeling anxious. And next thing we know, their BPs are always at around 70 over 30. They're falling down, they're not well, they're seeing things because of hypoperfusion and things like that. It happens, And then a lot of our patients, unfortunately, have poor understanding of the prescribed drugs. They don't know what their drugs do. They don't know why they're taking them. So sometimes they overdo it, And these are the most common: antidepressants, sedatives, analgesics, and corticosteroids. These are the most common ones that give us problems, all right? So still, recreational drugs and alcohol do apply. All people like to party as well. So don't take that away from them. They can also have a good solid time on the weekends, all right? So how do we know our patient is on antihypertensives? Okay, that we're talking about our patient. We'll get into that, right? Okay, so chronic illnesses. These are also things that can lead to an acute delirium. So the most common being neoplasm, any sort of cancer, simply because of metastases, generalized inflammation, multi-organ failure. These are also things that can cause an acute delirious state, okay? Chronic cardiorespiratory illness, again, perfusion issues. There's a lot of things that go on. Dementia is very one of those illnesses that can cause an acute delirium. And very often it's seen as an acute psychosis on top of dementia, but it's an acute delirium. And sometimes it can be for the reasons mentioned before. A patient may be ill, a patient with dementia may be overdosing, underdosing, may have subclinical infections. There's so much that can go on, right? And then, of course, chronic renal and hepatic disease, simply because of what you call it, waste buildup and electrolyte buildup and things like that. You know? So any of these generally result in chronic low functional status, but they can cause acute delirium as well. So the best person to listen to is the caregiver. They'll be able to tell you, especially what's been changing. So they know the baseline function, and they will tell you, but this has changed or that has changed. Now, those of us who work at Medellin, we know we get a lot of our patients from La Gratitude, and some of them have constant care. They have nurses with them all the time. Histories are well known, you know. They know their patients. They have, for example, in their higher care section, one nurse for two patients, you know. So there's those nurses really know. I mean, nursing maybe is pushing it, but those caregivers really know those who are there, they are in charge of, and they can tell you this is wrong. This person is not okay today. Don't gloss over it. Don't say, you know, take it seriously because something is going on. So if the caregiver tells you something has changed, treat it as an acute delirium first. In other words, use the approach of an acute delirium before you go to psychosis. All right. So, in any case, we get to our patient, and in his case, he was bedridden and things like that. And he lost the ability to function, or he went into an acute delirium. All right. So the question comes, what if there are known mental health care users? So if they're known mental health care users, generally they would have been diagnosed at a much earlier age. It's unlikely, like we said, for them to have primary. It's not impossible to have primary psychiatric illness. It's just less likely. Okay. So we still need to check why the change in the baseline. All right. And if there is an acute exacerbation in their psychotic symptoms, we manage them as an acute delirium first. So we look for all of these things that could be causing a problem, you know. So if you exclude any underlying causes, psychosis may well be the underlying factor. It's not a problem. And one of the best treatments of delirium is our commonly used antipsychotics in any case. So it could be non-compliance, poor dosing, things like that. So it doesn't mean you exclude completely, you know. It's just that you've got to think about it before you just go ahead and give it. All right. So we just got 3 slides for now. I hope you're learning something. My apologies too. I haven't been teaching you for the last few months. So if I'm not teaching as well, please. So these are just some slides to help you make you understand it and just to bring it a bit closer to home. So what happens in an acute deterioration? You've got to look for infection, electrolyte imbalances, neurological injury or neurological infection as well, endocrine and metabolic abnormalities, trauma, and environmental. Okay, so these are the things you should consider when approaching your patient. All right, it's simple. It shouldn't take you more than a few minutes just to get a history about all of these things. All right, and this is where history can guide you and narrow things down on where to start. All right, and your initial baseline examination can also tell you quite a bit. So put your hand on the patient, listen to the patient. You know, do things like that, you know. So we need to exclude all of these things before we move on, right? Okay. Let's look at some other ones. So when you look at the vitals, this is also extremely important. So what happens with BP? We may have an extremely high BP, which leads to hypertensive emergency and hypertensive encephalopathy. So that could be the cause. You could have dehydration, an acute shock state. Those are things that can also come from polypharmacy, infection, so on and so forth. Right? Temperature, infections. What about hypothermia, hypothermia? These can also cause a problem. Heart rate can be altered by drugs, infection. What about myocardial infarcts? There's so many things that can alter the heart rate. We need to look at the glucose. Is this patient now in diabetic ketoacidosis or hyperosmolar, what is it? HHS, sorry, and then hypoglycemia could also cause it. So O2 saturation, our SATs, is it a hypoxic illness, and then our urine. Now, in this one, why I mentioned this UTI is because I would say in my practice now over the last, what's it been, 20 years, I would put it at about 70% of the time. Elderly patients who present with what looks like an acute psychosis, 70% of the time I found that they've got a UTI. subclinical a lot of the time. It's only when you do dipsticks and when you get your white cell count back and you get all your infective markers back, your CRP, that you notice that they've got an infection. And even if you don't know what infection, but 70% of the time it's turned out to be this. So if you can remember this, you're going to cover 70% of the patient, then it goes down from there. These are actually not as common, for example, hypoxia. We tend to check for all of these things, but the urine is the one thing we always seem to forget. Oops, sorry. Let's get back to that. Okay, so you have to check for a lot of things, all right? And especially tachycardias, bradycardias, they need to be looked at, okay? And I just want to see if I must tell you guys everything. Oh, here I put it as 60%. I think I should rather change that to 70%. So what are the most common bacterial, why are they the most common bacterial infection in the elderly? A lot of them have catheters, a lot of them have incontinence, a lot of them have a neurogenic bladder, decreased cognitive function, so they tend to mess themselves. There's a lot that's going on, and decreased estrogen levels later on, both male and female, leads to a lot of dryness of the genital tract. It leads to excoriation, and it provides an avenue for germs to get in. Right? Insert a catheter if you can't obtain a specimen. Do not accept dipsticks that have been rubbed on a wet nappy. I've seen this done before, and it's not an acceptable thing to do. Okay, let's look at our last slide for today. So our jack hold as well. So jack hold is also something that we should be looking at. All right. So this also takes you about 2 minutes. All right. And it's something that you should look at, because it can tell you quite a bit. So if you just check that the patient is jaundiced, you've immediately ruled out psychosis. And that's the whole point of this, is that we need to work as in an exclusionary manner, exclude psychosis, make sure it's not the cause. And then when we've done all of that, then we can say with confidence, this is psychosis. Treat it as psychosis. And then if something else comes later on, but you've covered yourself in the emergency department. And that's all that people want. They want to see that you've got a thought process behind it. You don't just see this person coming in, immediately start writing your forms and push them off to a psychiatric department, where, in all honesty, there's nothing against psychiatrists, but they are there to look after psychiatry. They're not there to treat renal failure. And it's very difficult in most hospitals to get patients moved from one area to another. The doctors will say they'll co-manage, they'll do this, they'll do that. But we all know working, it's your bad luck that this patient ended up by you. Yes, I know this patient should have been mine, but I'm sorry, it's your bad luck that the patient ended up by you. And that's how people work. So unfortunately, if you can push the patient to the wrong ward, very often they're going to die in that ward as well, remember. So we need to look at anemia as well. All right. It's a common cause. Upper and lower GI bleeds very often leads to an acute delirium. Cyanosis, as we mentioned, clubbing can be hypoxia or tumor neoplasm. Remember, we had mentioned edema, cardiac issues, renal issues, lymphadenopathy, infection, and tumor can cause that, and dehydration. Okay, so these are just a few things that we've covered. I didn't want to make it a very long lecture. So next week, what we'll do is that we'll cover a case of delirium, and we'll try and use these as well. We'll go back to these and we'll try and figure it out. So I hope you guys enjoy. Hopefully, we look forward to another good year of studying together. And hopefully we should have something towards the middle to end of the year that will have all of these more nicely mapped out for you guys. So when you want to look back on it, but I'll let you know closer to the time when we get there. All right, guys, thanks a lot. I really appreciate it, and look after yourselves, and we'll meet again next week. Keep well. Bye.